Hello and welcome to today's live Coffee Talk CME webinar entitled Use of Simplified HCV Treatment Guidelines and Minimal Monitoring Recommendations Among People Experiencing Homelessness. This activity is supported by independent educational grants from AbbVie, Gilead Sciences, and ViiV Healthcare, and is jointly provided by Global Education Group and Integritas Communications. Now, let's turn things over to our presenters. Dr. Arsalan Shah and Dr. Stacey Trooskin. Enjoy the program.
Good afternoon, everybody. Thank you for joining us for today's program. And these are our learning objectives. Today, we're going to describe simplified HCV treatment and monitoring guidelines. We'll review reinfection prevention tactics that address the needs and circumstances of people experiencing homelessness, and we will identify community-based opportunities and logistics for co-location of HCV healthcare services with substance use disorder and housing programs. All right, so let's dive right in and talk about hepatitis C. As many of you know, hepatitis C is a virus that's transmitted primarily through parenteral exposures to infected blood, usually by means of injection drug use or sometimes birth to an infected mother. And over time, hepatitis C can cause scarring to the liver. A little bit of scarring is called fibrosis, and a lot of scarring is called cirrhosis. And cirrhosis, generally speaking, is not a good thing because it puts individuals at increased risk for hepatocellular carcinoma, end-stage liver disease, and death. You can see that there's been a real shift over time in terms of who's impacted by hepatitis C. We used to think hepatitis C was a disease of the baby boomer population. Those are individuals born between 1945 and 1965. But more recently, younger individuals have become increasingly infected and now make up the majority of patients living with hepatitis C. And it really is our millennial generation that is now disproportionately impacted by hepatitis C. So what is the status of hepatitis C in people experiencing homelessness? Well, estimates of hepatitis C among people experiencing homelessness range all the way from 10 to 52% versus around 1.3 or a little bit higher in the general population. There are multiple risk factors such as injection drug use, mental health comorbid conditions, and history of incarceration that are all found more frequently among people who experience homelessness. There are lower rates of hepatitis C testing among people experiencing homelessness, thereby increasing the risk of disease transmission. Individuals who know their status are more likely to take precautions to prevent transmission. And people who are experiencing homelessness are less likely to be aware of their status, usually due to that decreased rates of testing. And in a San Francisco study, only 42% of individuals experiencing homelessness who tested positive were actually treated. So we definitely have some work to do there. Now, who should we be testing for hepatitis C? Well, the recommendations have changed in recent years, and now the Centers for Disease Control and Prevention recommend that hepatitis C screening occur at least once in a lifetime for all adults aged 18 or older, and should also be occurring for all pregnant women during each pregnancy. Now, one-time testing, regardless of age, whether you're younger than 18 or not, should be occurring among persons with recognized conditions or exposures. So that includes individuals with HIV, anyone that has ever injected drugs or shared needle or other drug preparation equipment, anyone who's received hemodialysis, or those with persistently elevated transaminases, anyone who's been a recipient of a blood transfusion or organ transplant, and transfusions, I should say, usually occurring before 1992. Healthcare, emergency medical or safety personnel after any sort of occupational exposure to a potential bloodborne pathogen. And then for individuals who remain at ongoing risk, so individuals who are injecting drugs, and then also folks who have selected medical conditions, including those on hemodialysis, should be tested more frequently, at least annually. Okay, and then we should be offering testing to anybody who asks for it, irrespective of whether or not they're interested in disclosing what their risk factor is. And the reason why we want to have a low threshold for testing is that there is extraordinary treatment available. We can cure hepatitis C pretty easily. And so we used to think that there was subpopulations that were quote unquote difficult to treat or difficult to cure. And now all of those communities, all of those populations are now considered simple to treat and are eligible for simplified treatment guidelines. So individuals who have a history of injection drug use, anyone with co-infection, of course, people experiencing homelessness. Now, previous treatment failures are not simplified guidelines, but are still relatively simple to treat. Individuals with cirrhosis and those with chronic kidney disease are all eligible for cure, of course. And so the next challenge is really not about therapeutic choice, but more so to remove limitations for screening and treatment so that everybody has access to a cure for their hepatitis C. When we talk about simplifying access to care, it really is about minimizing steps from referral to treatment initiation. And so what you can see here on this slide is something that we call the HCV care cascade or care continuum. And you can see what happens to individuals as we move forward through time. So individuals who are tested as RNA positive, remember, you got to get that antibody test first and then confirm it with the RNA testing. That would make up the entire population that's chronically infected with hepatitis C within a certain subpopulation. So here it's 5 federally qualified health centers in Philadelphia. Then you want to make sure that you're getting the results of that test. Knowledge is power. And once people know their status, then they can go ahead and pursue treatment. You want to make sure that you're referring individuals to somebody who is able to treat, which if you're in a federally qualified health center like I am, where we have treaters, then the distance to getting that care is not long, right? You're co-locating those services. The provider needs to evaluate the patient. Staging needs to happen, ideally now as part of the routine visit that can just occur with very basic, non-invasive labs, initiating treatment, completing treatment, and then bringing individuals back for what's called an SVR assessment or sustained virologic response, which is defined as the absence of virus 12 weeks after they take their last pill. Now, you can see here that there are a lot of steps to get somebody to cure, but the biggest drop-off really happens between treatment initiation and seeing the patient for the first time as a treatment visit. So between that provider evaluation and starting treatment. And so figuring out models of care that make it so 100% of those who are evaluated or tested actually get into care or start treatment is really critical. And throughout the next hour, we're going to give you lots of examples as to how this can happen. Now, following a positive HCV test, a linkage to care team can aid in scheduling appointments and arranging transportation if testing and the site of treatment are not co-located. Non-specialist clinics or other organizations can certainly initiate treatment. We'll give you lots of examples of that today. Co-locating services in an FQHC is one way to do it. Co-locating services in substance use disorder treatment programs or syringe service programs are ideal. And really, treatment initiation should be as easy as possible. And any extra steps are really an opportunity for folks to disengage from care. There are simplified HCV guidelines. Treatment naive patients, meaning folks that have never been exposed to any type of hepatitis C treatment before that do not have decompensated cirrhosis, are eligible for these treatment guidelines. Now, simplification benefits both the patient and the treaters. Most treatment-naive patients without decompensated cirrhosis can use these guidelines. Pre-treatment assessment is really no more complex than that for newly diagnosed hypertension. Get some basic labs. And then hopefully at the next visit, you can start the patient on treatment. Duration is very brief now. Gone are the days of interferon where you would need to treat for nearly a year. Nowadays, we treat just for 8 to 12 weeks using anywhere from 1 to 3 pills one time a day. And it's using one of 2 pangenotypic regimens. And when I say pangenotypic, what that means is that these medications work across all genotypes of hepatitis C. So you don't even really need to be assessing genotype except in 1 or 2 rare instances. On treatment and post-cure monitoring is minimized. And so early in the days of DAA usage, we would bring the patient back, not infrequently, to have labs drawn. Nowadays, on treatment monitoring is minimal. And so really no lab work is required for most patients using simplified treatment guidelines. I always like to say minimal monitoring doesn't necessarily need to mean minimal contact, though, with your patients. A simple phone call, a visit to the clinic is fine, outreach is fine, but we don't necessarily need to medicalize things and draw blood every single time the patient is coming in. As I said, many people experiencing homelessness will be eligible for simplified HCV treatment. So who is that? Those are patients with chronic hepatitis C who do not have decompensated cirrhosis and have not previously received treatment. There are separate simplified HCV treatment guidelines for treatment-naive adults with compensated cirrhosis. And those who are not eligible are patients who have any of the following characteristics: decompensated cirrhosis, prior treatment, liver transplant, co-infection with HIV or hepatitis B, end-stage renal disease, currently pregnant, or known or suspected hepatocellular carcinoma. Now, just because those individuals may or may not be eligible for simplified treatment doesn't mean that treatment is not simple for them. Treatment now is very easy, even for individuals that fall into these categories, okay? So everybody can be cured that is on that list. Going through a simplified pretreatment assessment is part of the process. So within 6 months of initiating treatment, some basic lab tests need to be done, including a complete blood count, a hepatic function panel, some renal assessment, including an estimated GFR, and then calculating an INR within 3 months for patients with compensated cirrhosis. And then anytime prior to starting antiviral therapy, you want to make sure you have an HCV quant, otherwise known as a viral load. You want to make sure you've done your HIV testing as well as hepatitis B testing to assess for co-infection, and then a genotype if compensated cirrhosis is present and you're prescribing sofosbuvir or valpaticir. That is important. However, if the patient is not cirrhotic, then genotype becomes unimportant. Before initiating antiviral therapy, you want to make sure in people with a uterus who are capable of being pregnant, that you want to make sure you do that serum pregnancy testing and counseling about pregnancy risk associated with HCV medication, and make sure that if somebody is of childbearing age and potential, that they are counseled to use some form of contraception while on treatment. These medications are not currently FDA approved for use in pregnancy, although those studies are ongoing. A cirrhosis assessment is a critical part of pretreatment assessment. Liver biopsy is no longer required. We can use now non-invasive markers to assess for the presence of cirrhosis, including things like a FIB-4 or an APRI score or a platelet count. If you're curious about FIB-4, they have online calculators. The same thing with APRI. You just need your basic CBC and comprehensive metabolic panel will give you the information you need to put the parameters into these online calculators, and then you will have your assessment. And then certainly if you have transient elastography available to you, you want to make sure that you're utilizing that if you have it. Always conducting medication reconciliation is an important part of starting new medications, looking for drug-drug interactions, and then counseling our patients about the medications they're going to be taking, as well as the importance of adherence. is part of this process. So here's an example of what a FIB-4 calculation looks like, as well as the APRI score. Nobody's asking you to do this math on your own. I'm sure all of you are like, I haven't seen an equation like that since probably the 10th grade, but all of this can be done automatically for you using those online calculators. So what are we using to treat hepatitis C nowadays? Well, I'm not going to go into detail about the pros and cons of each medication, but suffice it to say that there are two pangenotypic regimens that are up here. One of them is glecaprevir pibrentasvir. The trade name is Mavorette. And then the other one is sofosbuvir valpatisvir, also known as Epclusa. Both of those are recommended for use with simplified treatment guidelines. GP is used for 8 weeks and is 3 pills once a day, all at the same time. It needs to be taken with food, which is important to note for somebody who may be experiencing homelessness and may have food insecurity. And sofosbuvir valpatisvir is 1 pill once a day, but is taken for 12 weeks. And so both of those two regimens are most commonly used in simplified treatment guidelines. One or the other can be chosen. So an important thing to assess before starting any medication for any patient, but certainly is true of hepatitis C, is to ask if the patient is ready for treatment. And so the patient has to be motivated and want to do this, right? We're not trying to force a cure on anybody. And then other pretreatment considerations. Again, none of these exclude a patient from treatment, but allow us as providers and treatment teams to come together and figure out how to build some scaffolding around patients who may need some more assistance. So can the patient be contacted by phone and or other reliable means? And we may need to think outside of the box for this. If somebody doesn't have a phone available, and your health center doesn't have resources to supply somebody with access to telephonic communication, then where are they staying? Can we get messages to them? Are they able to come in and see us when they need to see us? So how can we communicate? Does the patient have other active medical issues that are stable and good adherence to other prescribed medications? And if not, then what do we need to do to make sure that the patient has all the support that they need to adhere to hepatitis C medication? Does the patient understand harm reduction measures? So as many of you know, once individuals are cured of their hepatitis C, if in fact they continue to inject drugs and do not have access to clean drug preparation equipment like syringes, cookers, cotton, water, all of that, then reinfection is possible. And so we don't want to use the risk of reinfection as a reason to not treat somebody, but we want to make sure that our patients understand what harm reduction measures and resources are available to them and put them in contact with those resources. And can the patient articulate a plan to avoid Hep C reinfection after treatment? And again, we're not asking folks to sign in blood that they're not going to get reinfected, but we want to make sure that they have the resources that they need and understand what it takes to stay cured. Moving on to the simplified on-treatment monitoring, this is a study that was published called MinMon, which looked at minimal monitoring strategies during 12 weeks of treatment with sofosbuvir valpatisvir. In the study, no pretreatment genotyping was done. All the meds were dispensed up front, and no scheduled on-treatment in-person clinic visits or lab tests were done. And remote contact was done at weeks 4 and weeks 12. And the SVR rates at week 24 were high. Cure rates were above 95%. So this study really demonstrates that even with minimal monitoring, individuals are able to cure. Now, what I would suggest is that minimal monitoring may not be for all of your patients. I have a lot of patients that wouldn't feel comfortable receiving all 8 or 12 weeks of medication upfront if they're unstably housed. Some may want you to store the medication for them, but these visits that you have with patients to support adherence or medication storage or anything else don't necessarily need to be medicalized visits where we're drawing blood, phlebotomizing patients, and monitoring viral load levels in order to get them to a place of cure. Okay, just going to advance the slide. We're trying. Okay, oops, too far. So post SVR monitoring, though, is important for a number of patients, okay? Now, if somebody has minimal fibrosis at the time of hepatitis C treatment, you may want to monitor them for reinfection post-treatment. Okay, so you'd want to conduct a quantitative HCV RNA if somebody continues to inject drugs, or if you notice that they have some unexplained hepatic dysfunction and unexplained transaminitis. Certainly, you want to make sure that you are monitoring for reinfection in that setting after somebody has had a cure. Now, if someone has advanced fibrosis or cirrhosis compensated at the time you initiate DAA treatment, you still need to continue surveillance for hepatitis C with a twice-yearly ultrasound, plus or minus the AFP. You'll want to do a baseline endoscopic screening for varices if cirrhosis is present. And if varices are present, you want to make sure that you're treating that person and following with appropriate interval endoscopy. Now, if someone has decompensated cirrhosis at the time of DAA treatment, you want to refer all patients with any degree of decompensation for liver transplant. And I would even argue if someone has decompensated cirrhosis at the time where you're thinking of starting to treat them with DAAs, you may in fact want to refer them or do it in concert with a hepatologist or a transplant center. You always want to make sure that you're looking at the child's Turcotte-Pugh score and also the MELD score, and that is why it's helpful to do this in concert with a transplant hepatologist. Okay. So with that, I think I want to turn over to RC and have him move us through operationalizing some of these guidelines and talking to us a little bit about how he and his colleagues are treating in their health centers and establishing different touch points for people experiencing homelessness with hepatitis C.
Thank you, Dr. Trooskin. Thank you again for the great summary of the simplified guidelines. I want to start with, you kind of alluded to earlier about establishing touch points with the patient experiencing homelessness while they're getting treated. And I love that you mentioned, we don't need to phlebotomize them, but it is really helpful to have touch points because that could be really helpful in motivating them to stay adherent. Because as we can tell people that have food insecurity or housing insecurity, they have a lot of factors going on in their life, and we want to make sure that we're able to motivate them to, continue taking their medication. Some of the things that we used or is really helpful is incentivizing appointments, so that can encourage attendance, helping them link to other care like behavioral health care, mental health care, or even PCP care. That's also helpful. Making the dispensing of the medication be really easy. So like either with co-location or with a pharmacy or clinician, or if they are going to a MOUD clinic or sometimes they refer to OTP clinic, having them pick up their medication, Hep C medication along with their opioid use disorder medication. So just something to think about that really helps in making sure that we have those touch points with the patient. And another thing that you alluded to earlier that really helps a lot with our patients is patients that have housing insecurity or they don't have storage. We do allow them to have either daily dispense or weekly dispense. And those are another checkpoints to just kind of really check and see how they're doing, if there's any side effects and things like that we can help them. All right, so we'll jump into discussion about what we were just talking about. What strategies can encourage retention in care and multiple touch points for patient experiencing homelessness with HCV? Dr. Trooskin, if that's okay, I can jump and kind of talk about some of the things that we use, and please feel free to chime in. Some things that we use that really is helpful is a lot of times the incentives will work. When we have a grant, we use a lot of those incentives to just have people come talk to us. We also encourage, especially for people that are on shorter dispense, like a daily or a weekly check-in, we have sometimes like some sort of warm food for them, like a cup of noodles or things like that. That really helps them, kind of encourage them to come in. At one point, we were running a cell phone program. So then they had to call us to do minutes, to come check in on their minutes. And that was another way to check in. And one thing that we still employ that's really helpful. So we do have community health workers that are out and about. The person that initially started them on their journey to be cured of Hep C, that person will usually kind of check in just casually, like drop by their tent or drop by their shelter, like, hey, John Smith, how are you doing? How's the medication? And if we have any red flags or if we hear something, then they'll connect them to the pharmacist or the clinician to make sure that anything that needs to be addressed, that is really addressed.
Yeah, I agree. All of those are strategies that we've used as well. I think we have done our very best to try to get a couple of different modalities to reach out to patients. So if they can't come to us easily, doing some of that community health work that you've described, knowing where they hang out, where folks cash their check every month, making sure that we have some way of getting in touch with them, all of which they provide to us willingly, knowing that life can be a little bit chaotic. So that's extremely helpful. The hot meals, warm pair of clean socks also can be pretty meaningful to folks too, or some used shoes, having a bit of like a clothing closet, a used clothing closet, particularly when the winters get cold, having coats or sweaters or things that folks can layer on is another incentive that brings folks in to take care of other needs that they have, not just their medication. So I agree. All of those are good strategies.
Thank you. What a great add-on. We actually have a clothing service that we never thought about incorporating with our check-ins. So I have a take-home message to take. All right, let's move on. Okay, so Dr. Trooskin kind of talked about what medication therapies are available out there, and it's really simple. The treatment is really simple. What we're going to talk about a little bit in the next, this slide and the next, is what the landscape looks like for accessing this medication from a Medicaid standpoint. So as you can see, we can see the difference between 2014 and 2022 in terms of what the restrictions are, either from the state or the PBMs. In terms of fibrosis restriction, we can see in the last 8 to 9 years, we've made a lot of significant progress where there is not a whole barrier of restricting fibrosis before it's initiating somebody under treatment. We've also made huge strides on sobriety and substance use requirement. From 2014 to 2022. However, there's still many states that do require sobriety of some sort, which can be a barrier for HCV care. And as we kind of learned from Dr. Trooskin earlier, that none of those are necessary in order for somebody to be successful at getting cured for Hep C. And also in the last purple graph, you can see at the bottom, the purple map, is that prescriber type of restrictions have been lifted in many, many states. But there's still some restrictions are in certain states. So depending on the states that you're working in, you may want to consider these type of barriers as you're prescribing, or the access from your patients are going to have to kind of think through that treatment aspect. And some of the other requirements that we have that currently exist in 2022. So from the leftmost map, we're looking at if the states require prior authorization. In 2023, I know Oregon is one of the states that does not require prior authorization anymore, but generally, as we can see, most of the country does require prior authorization. And that's something that as a nation, if we're trying to eliminate Hep C, we definitely need to lower that barrier, because that logistic burden can be a lot for the providers and sometimes for the patients as well. There's still a lot of retreatment restrictions out there that are from the state. So that's another barrier there. There are medications available that work excellently for retreatment, but we still see a lot of barriers in terms of accessing that medication. And then besides the prior authorization or retreatment requirement, managed care or PBM can sometimes have additional barriers. They can put a lifetime restriction. They can put a certain amount of, you can only lose this many medications, or all these other things that they can have. And as you can see, there are some states that do have those managed care requirements as well. Something that many states also have is that a lot of times Hep C medication has to be dispensed out of a specialty pharmacy versus your regular pharmacy. So that can be sometimes for the patients can be a barrier from accessing that medication. So something to consider as well. And we're going to switch gear a little bit, and we'll talk about prevention of Hep C and from a harm reduction lens. And Hep C prevention should be, if you're working with this patient population, kind of be always talked about from starting from pre-infection to post-SVR. Some of the modalities and tools that we can use is making sure that we're talking to patients about the behavioral risk reduction, harm reduction strategies of how can they reduce the risk, increasing access to testing, and once somebody is tested positive, like linking them to care right away or finding ways for them to access treatment right away. Once again, somebody is positive, RNA positive, we should treat them as soon as possible, and then consider treating their partners in the household, or also their partners or the groups that they may be injecting with, and consider treating them as well. And then just reiterating the importance of harm reduction, and just encouraging risk reduction in the behaviors that they're engaging in, even post-SVR. And something that at our agency that we really enforce the education about how to prevent getting Hep C infection, and just making sure that education is stigma-free and from a harm reduction lens, because that has been proven to be very effective with our patient population. And so we talked about preventing of Hep C infection. Let's talk about reinfection with our patient population a little bit. So Hep C, getting cured of Hep C does not mean that a person is cured for a lifetime. Actually, let me rephrase how I said that. Getting cured of Hep C does not mean that you cannot get that infection again. The risk is very low, but the risk still exists. So we have a study that we looked at, or just on our slide, that the approximate rates of reinfection in different patient populations. So, for example, patients that had a recent drug use, the infection rate was 5.9 person per 100 person years that were monitored. In people that they were actually injecting drugs, the rate was just a little bit higher at 6.2 per 100 person years. And the people that were actually receiving care for opioid use, so medication-assisted opioid use disorders, the infection was the lowest at 3.8 per 100 person years that were monitored in that study. That just basically shows that people that are connected to care are least likely to get reinfected. And we should not use the risk of reinfection to be a barrier to providing somebody care. If they have Hep C, we should treat them. And I love what Dr. Trooskin mentioned earlier. If somebody is RNA positive and they want to get treated, that should be the criteria to get them treated. And using treatment as a harm reduction measure or treatment as a prevention measure, making sure as soon as somebody is RNA positive, they're treated right away. Also, reducing the risk of getting infected or getting reinfected via harm reduction measures like access to needle exchanges, providing education, providing treatment for opioid use disorders, medication-assisted treatment. Access to treatment is something I talked about already, without stigma, without discrimination. And it shouldn't be talked about. A reinfection is something shouldn't be talked about a patient that messed up or a patient that did not do what it's supposed to. That is just a stigmatizing way of approaching that, and that could be harmful in the treatment of Hep C. And then individual level treatment strategies, talked a little bit about earlier, making sure that treating of patients' immediate partners or the group, if we can identify that they are sharing drugs with, or they have a pod that they are sharing equipment with, that we talk to patients about getting those people treated as well. And then community engagement and partnership. From my personal experience, peer educators are very, very helpful. Patients are much more likely to respond and be more likely to be engaged in services when it's coming from peers that have had similar experience to them. And this is a graph kind of showing what I was talking about earlier about treating early on as much as possible. So on the graph on the left side, if we look at the bottom, treat 10%, the early and as much as we treat, the peak will be lower and the time will be compressed in terms of reinfection rate, so we can eliminate Hep C at a faster rate, versus if we treat a lot slower or a smaller patient population, then the peak will be extended out and the time it will take to treat, that will also be extended out. So it's just much more effective to treat as much as possible and as early as possible, as shown by the study that we're looking at. And preventing reinfection, just also remember harm reduction measures are just so important. Again, medication-assisted treatment for opioid use disorders, providing access to education, sharing services, and then just increasing the amount of people that can do linkage to care. That could be a Hep C coordinator, that could be a community worker, whatever you want to call it, just the people that are helping people get treated for Hep C. All right, so our discussion point is how can you best educate patients about preventing reinfection? Dr. Trooskin, you want to go first, and I'll add my...
Yeah, I think the where I always start is having an honest discussion with patients about what they're doing now. And so really being able to understand what their risks are in real world settings makes it easier to then provide them with some guidance around how to prevent reinfection. And so if I have a patient that's still using drugs, I'll ask them if they have their drug using equipment on them and ask them to show me what they're using and how they're using it. I'll ask them where they're getting their syringes from. And if they're reusing their syringes. And all of that information is an opportunity to intervene and practice some harm reduction with them. If they're reusing syringes, asking if they're using with other people or by themselves, making sure there's access to Narcan, making sure that they know where they can get clean syringes and clean drug injection equipment. So all of that is critical, knowing where folks are starting, so then you can guide them where they should be moving towards.
Thank you for sharing that, and I 100% agree with that. A lot of times that our providers would also kind of talk about to the patients, it's some of the non-IV drug use that they can still get, because Hep C virus is so small. It's like 100 times smaller than HIV, and it can live on inanimate objects. So for example, when somebody who's doing cocaine, for example, and cocaine as a crystal can cause some cuts in the nostril, and the Hep C can stay on it. So a lot of times their patients are not aware of that type of thing. So even sharing straws or different things like cotton, that we also make sure that we talk to the patients about that. And what you talked about earlier is just being okay with talking about drug use in a manner that the patient feels also comfortable. Like a lot of times the providers will kind of speak in the lingo that the patients are using, refer to the drugs that they're using, and just being okay with like, okay, what are you using? How do you use that? And those are just so important. And patients, then once they feel a little comfortable, then they're much more likely to share because it's just that point of having that initial conversation or bringing up that point in a manner where you can make it okay to talk about this. Thank you for that, and we'll go ahead and move on to our discussion. And so the next few slides, we'll kind of talk about different models that exist currently, and we'll highlight a few different things that are available or that's happening out there. And there's some studies that kind of show that these model works, and I'll try to put some input of like what we currently do at our sites and what works for us. So this slide, we're looking at benefits and logistics of co-location within OTP, an opioid treatment provider, or we can call it an MOUD program for MOUD providers. And in this trial, they looked at patients that had an SVR 12 and a co-location of that. And then on the graph, we can see patients that were always on MOUD had a response at about 90% of SVR, achieving SVR. Patient that started MOUD and retained had a 92%. And then we can see if they stopped or if they never had MOUD or they never took MOUD, those rates tend to be a lot lower. So the message of this slide that we really want you all to take is that having a partnership and collaboration with an opioid treatment provider is so vital for our patient population because that patient population does tend to be a little bit higher in terms of their RNA positivity. As Dr. Trooskin mentioned earlier in the slide, that's just so much more compared to the average patient population of like 1 to 2%. Our personal experience, we've been collaborating with a MOUD provider for about a year, and we see up to about 20% positivity rate where we are with those patient populations. Another example is collaboration here in the study between with a syringe service provider or syringe service program where a Hep C treatment was provided at a syringe service program. Testing was performed at the site, and we can see about 80 to 93% who were experiencing homelessness completing treatment in SSP did achieve SVR, which is amazing. That's like really, really high results. And then going back to if they were receiving MOUD or not, we can see the people that were receiving MOUD tend to have better outcomes. So just being connected to different services, especially services for the opioid use disorder, does tend to have a better outcome impact to our patient population. And then on this study, they looked at a program that provided Hep C care in a shelter. So in this slide, next slide, we kind of talk about some of the barriers that face, some of the things that help, that helped the program. And then the next slide, we'll kind of talk about the recommendations that came out of the study from the research group. So some of the barriers of having a treatment within a shelter. Obviously, we talked about the insurance access and policies that can have an impact on it. There's workforce constraints in the shelter. Those of you who've been in the shelter, there's a lot going on there. So I can imagine that being a constraint. Not enough time to perform the testing and treatment and counseling. Limited healthcare infrastructure of like being at the right providers at the right places. Not having labs or pharmacy on site could be a barrier there. And that's something personally that we feel still sometimes. There is a narrative, not just amongst the patients, but sometimes amongst the case management group that is not part of healthcare, that they still carry the idea that Hep C treatment requires this massive interferon, the old days, that it's very expensive, it's very hard, and it's not very effective, and just kind of re-educating and providing the right education to the staff as well. And then overall, just the low HCV treatment knowledge, shelter policies can be a barrier. And then from an individual patient perspective, a lot of the patients have competing priorities. They have behavioral health needs, mental health needs. They may not have IDs, or they need to have a job interview. So some of those things that they are more acute to their, that they're trying to do at first before getting treated for Hep C. And then the stigma that comes with Hep C, or being treated for Hep C, or just, they might be dealing with behavioral health or mental health that may want to prioritize, but that doesn't allow them to prioritize thinking about their Hep C care. Some things that has helped, according to that study, that helped with this model was the state policies that were a little bit more friendly to getting patients treated for Hep C. Buy-in from the city and county officials that really helped them, receptive leadership and organization culture from a harm reduction standpoint, and also that, hey, we need to treat people and cure people of Hep C, education for the staff, and both from the patient perspective and the entire staff, and then providing linkage to care. And then patient attitude. There's a lot of times myths that people don't really want. People experiencing homelessness don't care about their health, or they're not prioritizing sometimes. But a lot of the patients that are positive do want to be treated for Hep C, given that they have the opportunity to get themselves treated. And then just a prescriber attitude is also helpful when setting up any collaborations with shelters or any co-location services. Some of the recommendations that came from that study, again, that anybody else who's trying to do this, offering the shortest possible course for HCV therapy in this patient population, that makes sense. Our patients are dealing with a lot, so trying to get them treated as quickly as possible. Having a person that can be an HCV coordinator, or whatever terms that you want to use, that could basically facilitate providing testing or providing results or coordinating the treatment, but doesn't have to fall onto the shelter staff or the entity staff where you're trying to collaborate. Using different motivations, whether it be incentives or different motivation factors to engage patients, that could be really helpful. Providing education for the staff, offering peer navigation or support groups led by peers. As I mentioned earlier, personally, that's something that we've noticed as well. Our patients tend to respond a lot better to our peer navigators versus those are not peer navigators, or people that have not had the similar experience to our patients. And then lastly, just providing education for our patients as well. And that's just something really, really helpful. And not just Hep C education, how to prevent getting Hep C, harm reduction education, and that's really helpful for that. And then I believe we have one more discussion point. So what are your success stories for collaborating with external resources, such as MOUD clinics, to treat patients experiencing homelessness with Hep C?
Yeah, thanks for that question. We've had great success in working with methadone programs and inpatient substance use disorder treatment programs to treat. And for the methadone program, there was an internal champion that really wanted to prescribe and have other addictions providers prescribe hepatitis C treatment. And so we provided some mentorship, some guidance, some technical assistance around not just the ins and outs of prescribing, but also supporting folks in implementing a workflow that worked for them. And now medication is dispensed along with the methadone every day, or if somebody has take homes, once a week. And then for the inpatient drug treatment program that we work with, we actually send a staff person, an outreach worker, down to the inpatient site. We do telemedicine, and that outreach worker also is a phlebotomist and is able to draw the necessary blood from the patients. And then all of the treatment happens remotely. We bring the medications up there. We do check-ins with folks, and we try to get everybody treated before they're released. And if they're released mid-treatment, then they come in and see us in the clinic setting.
Oh, that's pretty amazing. Thank you for sharing that. We started a collaboration with an MOUD clinic, as I was mentioning earlier here too. And what we were really successful in implementing a workflow, because the MOUD clinic that we worked with, they were required federally to collect the syphilis test every year or at initiation. And then we were able to work with them to include Hep C and HIV testing along with that. So then we just implemented a workflow that everybody that was getting syphilis tested is also getting tested for Hep C and HIV. And if somebody is positive, there are back channels. If the patient is interested, they then automatically get funneled with us. And then there's a warm handout. And that has been really helpful from partnership standpoint. And in just 1 year, we were able to screen like 700-800 people. And you know, our linkage to care is better than what we saw on the study that you mentioned earlier, but still that's something that we feel like we can focus on with telehealth services. And this year, our focus is to start working on linkage to care and telehealth.
Awesome. Well, we're almost at the top of the hour. Why don't we go through these conclusions and see if we have time for one question?
All right. So let me summarize this. Great discussion. And then Dr. Trooskin, I will hand it out to you. So we talked about all patients who are interested in treatment are eligible for treatment. So we shouldn't put any barriers in treatment. The reflex testing algorithm directs interpretation of antibody and antigen results. So, try to utilize as much as reflex testing as possible. Many can be treated using simplified guidelines, especially with the population that we're seeing now. Most, I would say, the patient population that we see can be treated with simplified guidelines. Fibrosis, sobriety, and PA requirements are a barrier, and that would hopefully change as the time comes, as states become more progressive towards treating the patient population. Patients should be educated about strategies to reduce the risk of reinfection. And there are multiple models for collaboration with shelters available. Some of them we shared today. Some of them are, out there. And both Dr. Trooskin and I would be happy to share if somebody wants to reach out. Sorry, Dr. Trooskin, I just told you. And then I will hand the mic to you.
Okay, that's great. Well, thank you, everybody. We were able to answer a couple other questions. The folks just told us we can stay on for another minute or two. And there's some great questions that came in. I think one or two I can get through pretty quickly. The first one is a great question for an individual who's completed HCV treatment successfully. How long would it take for the individual to test non-reactive with an OraQuick type test? So this is a really important question, and I want to make sure that I just really specify for you all and clarify that antibody test is something that measures if you've ever been exposed to the virus, right? It doesn't tell you whether or not you have the virus. You need a confirmatory test for RNA for that. And so the RNA test is the thing that will turn negative once you've been cured. The antibody test usually stays positive forever. Just like all of us, if we test for antibody to COVID-19 and we've had it in the past, we will be positive for COVID-19 antibody. It doesn't mean we have COVID-19 right now. And same thing is true for hepatitis C. So it's really important to counsel our patients that once they're cured, an OraQuick or a rapid antibody test, or even one that's off a blood draw, is always going to be positive. So it won't help the patient understand if they've been reinfected. So it's really important to make sure the patients know that, because if they go and they get, like, let's say, blood work done for life insurance, the antibody test will always be positive, but the confirmatory test is what needs to be done in the future, that RNA test, okay? Another really good question that can be answered quickly is, are there any active initiatives we can join or support that are working against those prior auth requirements? And there are. The National Viral Hepatitis Roundtable has partnered with the Harvard Center for Health Law Policy and Innovation to do those maps that RC put up and walked you through, showing where the the restrictions and prior authorization criteria still are. And so if you're interested in advocating in your state for removal of prior authorizations, go to just Google the National Viral Hepatitis Roundtable, or NVHR, and you can reach out to the folks that oversee that program, and they can give you resources, tools, put you in contact with other people around the country that have worked to address prior authorization. And I think, RC, we have time for one more that I'm going to put to you. Are there any DAAs that are more forgiving than others as far as skip doses?
So I'll speak from my experience, more so than a clinician doing guidelines, that both MAVRID and Inclusa, we have seen our patients that have skipped several doses, and they're SVR positive. Obviously, how we counsel patients, we don't ever mention that, like, hey, you can skip doses, because, then they take that differently. But we have seen people skip doses and still be okay and with SVR. There are guidelines now, I believe there are updated guidelines of, like, when patients skip doses, like whether you restart or retreatment, and I believe they're in the AASLD guidelines. So if you're looking for more specific things, are there. But generally speaking, from experience, we have seen people come positive, and sometimes they've missed total of, out of 8 weeks, randomly here and there, they would miss like 6 or 7 doses. But please, know that I'm experienced from anecdotal experience.
I will also add that there was recent data presented by Dr. Alan Litwin at AASLD this year from the HERO study, which is sort of like a real-world study of treating people who use drugs, so not necessarily people experiencing homelessness. But that data hopefully will be published soon, and had some really great real-world data to show that if somebody missed 10% of their doses, then the SVR rate was X. And if they miss 30% of their doses, the SVR rate is Y. And so hopefully that data will be forthcoming. If I had committed it all to memory, I'd recite it for you today, but I don't have all of it. Suffice it to say that less than perfect adherence does still lend itself to SVR. So with that, we are out of time. I want to thank all of you for attending today. I want to thank RC for sharing all of his wisdom and knowledge with us. And thank you all for your time.